multiple myeloma is associated with a high risk of venous thromboembolism. Now, this is particularly true in patients receiving thalidomide or lenalidomide therapy. So there are guidelines that stratify patients into low or high risk of thrombosis to help guide preventive therapy, but are the guidelines actually making a difference is a big question. So to answer that, we're talking about a paper here at ASCO, validation of a thrombosis risk assessment model in patients with newly diagnosed multiple myeloma. And to do that, I am with Brea Lipe, who is an MD and an associate professor and clinical director of multiple myeloma at the University of Rochester in New York. And you're actually in transition. You're formerly of Kansas University Medical Center. First off, thank you very much. And this is, for me, particularly an interesting topic. How big of a problem is this in multiple myeloma?
It's actually a big problem. And we're really getting to a better point where we can understand how large the problem actually is. So we've known for a while that people with multiple myeloma have a higher risk of clotting. And then as we developed therapies for this cancer, we learned that people clot even more than we thought that they did. And some of the therapies that we use to treat multiple myeloma, if patients aren't prophylaxed, they have a risk of clotting of over 30% in some of the studies. So it's a pretty big problem.
So what did you set out to learn with this study?
So there have been guidelines proposed because we understand that there is this risk of clotting. There are guidelines to help try and minimize the risk. The question is, these guidelines are derived from sort of anecdotal evidence, from sub-studies of larger therapeutic trials that look at subsets of populations that are pre-selected because of these clinical trials that select for very healthy patients. So the question is, does this work in the real world? And are we doing enough in the real world?
So what did you do? Specifically, tell me about this study.
So we did a retrospective case study, and we looked at patients at the University of Kansas who had had a blood clot who had multiple myeloma. And then we matched those patients to patients who hadn't clotted. So we matched them based on their age, their gender, and the time of their diagnosis. And we looked over about a 10-year period. And we came up with about 90 patients who had clotted, 89 patients who clotted, and we matched them at about 1 to 3 to patients who had a diagnosis at a similar time, same gender, similar age, who did not clot, and looked for differences in those two populations to see if we could understand why some people clotted and why others didn't.
I thought some of the stuff you learned was quite interesting. What did you find out?
So what we found out is that if you look at the prophylactic recommendations that were put out by the International Myeloma Working Group, they're not really followed very well. So we found that about 60% of the patients in our cohort of patients, both the clotters and the non-clotters, were what we would consider to be high risk, meaning that they had multiple risk factors for developing a clot. But of those 60% of the patients, only about 16% of them ever received the recommended prophylactic for that condition.
Well, one thing I found interesting is patients with multiple myeloma, the guidelines say, should receive appropriate thromboprophylaxis based on risk factors for the first 4 to 6 months of treatment. But when did you find the median time when this occurred?
So our median time was actually several years later. And when we looked at that, when we substratified that out, because it's kind of expected in the literature, at least what we've believed up to this point, is that people clot, the risk of clotting with multiple myeloma is highest within the first 6 months to a year. And we found that actually about 25% of our patients clotted within the first year, but then even past 2 years, about 45% of our patient population developed their clots after the 2-year mark.
So the question is, number one, what do we learn from this? And number two, what in the world can we do to improve prophylaxis in this setting?
So I think we learned a couple of things. One is that we're probably underestimating the risk over the duration of the disease. So when we look in the real world, there's other evidence coming out as well that we suggest it's not just the first 6 to 12 months that matter. It's this prolonged course, and as long as they have the disease, they have a risk of clotting that we shouldn't ignore. I think what we also learned is that the guidelines that we have aren't followed particularly well, but even when we looked at the guidelines, they didn't seem to help. Even when patients were following the guidelines, it didn't separate out the patients who followed the guidelines versus those who didn't, clotted or didn't clot. So we might not be identifying the true risk factors for clotting. It might be that there's some disease biology at play or other factors that are important that we're underappreciating.
What needs to be done next?
I think what we need to do next is we need to develop better prospective studies to look at patients from the time that they're diagnosed to understand exactly who's clotting why. I think it would be great to do more analysis of the actual samples of patients to find out what within their biology might make a person who shouldn't clot because they don't have risk factors, they're not on high-risk drugs, they clot anyways. What makes them different from someone who is the classic patient we would expect to clot? What makes them different? Is it in their biology, or is it something else that we're not appreciating?
Based on what you know now, how would you handle a patient differently?
I think I would be more vigilant about what prophylactics they're on from the time of diagnosis and at every time I see them and change their therapy. Another thing we found in the study is that patients, they were stratified when they were first diagnosed, but there didn't seem to be stratification and modification of their thromboprophylaxis as the regimen has changed, correct?
Yeah.
And so I think that's important.
Because you're talking about years into, since
Correct.
the diagnosis, make sure you keep checking that patient, assessing that patient as you go along.
Absolutely, and understanding what their risks are and how they change from moment to moment and based on the patient's life.
And what specific risk factors would you be looking for?
So
Which ones do you think are the most important?
within the study that we found, I think we found that smoking is definitely a high risk factor. Obesity, diabetes, these are the things that we know to be risk factors. And while my particular study didn't flesh out as independent risk factors, that's sort of what we know, and until we develop a better model, I think that's what we have. I think the other thing coming up is with the new oral anticoagulants, how does that play a role, and is it make it easier to prophylax patients, because it's hard to tell patients to give themselves another shot every day.
I spend a lot of my time in cardiology, so these are all issues that we deal with on a daily basis, so I really wanted to chat with you.
Well, it's been my pleasure.
Thank you very much, and we have a lot of coverage from ASCO 2016, both in print and online. Please check that out for American Medical Communications. I am Rick McGuire, an executive editor.